Emily will give us some housekeeping items.
Good morning, everyone. For those of you looking for continuing education, medical or nursing credits, please complete this survey. And I'll share that link a couple times throughout the hour. Towards the end of the session, I'm going to be sharing a separate link that is just a few questions to get some feedback on how these sessions are going and how they can be improved. If you haven't done so already, I'm going to invite you to mute yourself. Feel free to ask questions in the chat or at the end. You can ask them out loud at the end of each session. And as Brian said, we are being recorded.
Great, thank you. We have some great presentations today. We have Imani Ransby presenting on epi updates for the area. We also have Dr. Jorge Mira doing COVID-19 updates, and Jennifer Downs, who is doing burnout and self-care for professionals. And we'll go ahead and get started with Imani Ransby.
Thank you, Brian. I'm going to share my screen now. Is everyone able to see my screen?
No, we're not.
Okay, give me 1 second. How about now? Okay, great.
Good, very good.
Okay, so good morning or good afternoon. I'll be providing a brief update on the COVID-19 epidemiology in our region, and specifically focusing on the aggregate data, as we have done in past updates on previous ECHO sessions. Please note that we did last give this update on 8/28, which was about 2 weeks ago, as we did not meet last Friday, and that's just something to keep in mind as I'm referencing these new numbers here. So the information displayed on this slide has been obtained from a total of 26 sites that have been reporting COVID-19 testing data to IHS or the Indian Health Service. The 26 sites, within those 26 sites that have been reported, we did see an increase in the total number tested, positive and negative. The total number tested increased from 23,287 to 25,208, while the number positive also increased from 1,881 to 1,932. And then the number negative, we also saw an increase there from 20,731 to 22,538. So overall, we are still seeing an increase in numbers, but things do appear to be slowing down somewhat. So on this slide, here we depict the cumulative incident rate within the 13 USET states. As you can see, we have provided a USET state rate, a county rate, and then the United States rate for confirmed COVID-19 cases. Please note that the USET county rates are obtained from information gathered from purchased and referred care areas. And from this graph, it is evident that the USET county rate continues to be higher than that of the USET state rate and then the United States overall rate. And again, this continues to be the trend that we've pretty much seen throughout. And just to go into a little bit more detail, I'll just go through these numbers. So the USET county rate increased from 249 per 10,000 to 255 per 10,000, while the USET state rate increased from 223 per 10,000 to, oh, sorry, my screen is cut off, to 230 per 10,000. And then the United States rate increased from 185 per 10,000 to 193 per 10,000. And lastly, I just want to mention that we are still offering the COVID-19 surveillance tool to assist tribal nations with tracking COVID-19 cases and contact tracing. So if you are interested in this, please do not hesitate to reach out to us. Alternatively, if we can be of any assistance with anything else, please feel free to reach out at usetepi@usetinc.org. Thank you.
Thank you, Amani. Do we have any questions for Amani? Hearing none, we can move on to Jennifer Downs.
Okay, I just unmuted myself. I'm going to go ahead and share my screen and see. And we'll just do it from the beginning, see if that goes better for you all. Can you see? Okay, all right. So just to introduce myself, my name is Jennifer Downs. I'm a clinical social worker. I'm a member of the Washoe Tribe of Nevada and California. I worked for IHS headquarters on and off for about 6 years in different areas, but all in behavioral health. And I just recently, just in mid to late July, moved over to the Nashville area. So I'm very much in a learning process right now, getting to know different members of the staff within the area office, and then learning about the tribes, meeting members of the tribes and members of behavioral health staff within the tribes and within urbans and the federal service units. So actually it's all really fun for me right now, because it's really just relational, getting to know people and trying to understand processes, those kind of things. And then I still deliver services 1 day a week via telehealth. So that's my happy day. I call it Therapy Thursdays, and those are my happy days. So that helps me to still stay inspired for the administrative side of things. But that's a little bit about me. I work full-time telework. So even when we are able to return to the area office, I'll still be working from Missouri. But I'll travel from time to time and hopefully get to meet everybody face-to-face at some point. So that's my little intro about me. Today we are going to be talking about burnout and self-care. And I just wanted to say thank you to USET for offering me the opportunity. It's an honor to be able to get to speak to you all, especially being new and just coming in. So thank you. And as I'm talking, if you do have questions arise, feel free to interrupt, but I will also have time at the end to just have conversation. And I'd love to hear if people have some creative ideas, and I'll talk more about that at the end to hear that kind of feedback. But if you have questions, we can talk about that as well. But I put an agenda in so you know what's coming. So we'll talk a little bit about terminology, because I hear all kinds of words thrown around when it comes to burnout, secondary traumatic stress, compassion fatigue, vicarious trauma. And I think we're all kind of talking about the same thing for the most part, but I'll talk a little bit about those terms to start us off. And then we'll talk about risk factors, for whatever term you're using, risk factors for that negative impact that can come into our work as providers. Talk about tips for individual self-care, and then we'll kind of wind down with organizational strategy. So if you are in leadership and you're looking at your employees, things you can do to help them to address or their burnout, or to stay well and not get there in the first place. So I'm going to rely on my notes a little bit when I'm talking about all the terminology. Like I said, they're distinct terms, but they really all kind of overlap and refer to the same thing. But when it comes to the term compassion fatigue, that's referring to the emotional and physical fatigue that we experience as providers when we're chronically engaging and using empathy when we're helping people that are in distress. So that's compassion fatigue. Vicarious trauma and secondary traumatic stress, probably more than any of them, are used interchangeably. That really, they're terms that were coined by different people at different times, but they're really about being exposed to an individual who has experienced trauma. And so studies have been done in first responders and behavioral health providers, and seen that when someone is experiencing secondary traumatic stress, that they can have all the same symptoms as somebody who has PTSD. So you see the same things of somebody potentially disassociating, avoiding triggers, having thoughts that they don't want to and they can't control them, that are interrupting their life, hyperarousal, those kind of things. Vicarious trauma is the only slight difference is that it's more about the profound shift that in a worldview. So that whole negative shift that can come about the way you view the world in general when you're experiencing trauma, even though it was through someone else's experience. Burnout is a term that has been used to describe the physical and emotional exhaustion that providers can experience when they have low job satisfaction, they're feeling powerless or overwhelmed at work. It doesn't necessarily mean that their worldview has been damaged. It doesn't necessarily mean that they no longer have compassion, but it can be that and all of those things together. They can all be happening at once. So I put this in here because I think the term compassion is a beautiful term. It literally means to suffer together. I think it's beautiful when we as community members and as Native people laugh together, rejoice together, and when we suffer together, that helps. But as a provider, what can happen is that you're doing a whole lot of suffering together, and that can be overwhelming and draining and get to a point where you're not able to do it anymore. So are your faces all showing on your screen too, like covering up the words? I'm just checking. I'm moving you. Okay. They were for me, so I moved everybody. So I put this quote up here: the most insidious aspect of compassion fatigue is that it attacks the very core of what brings helpers into this work, their empathy and compassion for others. So that can be the really sad part of what happens in compassion, is when you get to that fatigue piece, and what brought you there is now what's making you probably want to run away, or leading you to a place where it's very difficult to move forward in your work. So burnout is typically characterized under three areas: that you have emotional exhaustion related to work, but that can also be outside of work, and we'll talk about that and the realities of that during COVID. Depersonalization, or a more common term would be cynicism, and then a reduced sense of personal accomplishment. This is kind of when you're hitting the bottom and staying there when we're talking about burnout. I wanted to talk about, especially during COVID, specific sources of stress that come into play for healthcare workers. There's the physical strain if you're having to wear protective equipment all of the time, which can lead to dehydration, heat exhaustion. Physical isolation and stigma. So even there's that piece at work where you're having to keep distance when you can. But then even after hours, and I know this has happened personally, my daughter is more susceptible. So when all of this started, we were very careful because of the risk factors in her life. And our church was starting to meet in small groups and homes, which we would have loved to do. But then I found out that there was a healthcare provider that was coming straight from work to the group, and I was like, well, we will not be joining that. And then, but I also started thinking about what she must be encountering on a regular basis, and how people are likely to stay away, and how they may be making those choices themselves. I know of a lot of people that are trying to distance even at home if they're constantly in a medical environment. So there's that whole level of stress going on. There is a constant awareness that healthcare providers have to be managing for infection control, for all the new procedures that have gone in place. There's pressures regarding following those. There's a constant back and forth between work and family. And I know in our own home too, with my husband works in the community on a regular basis, and multiple times now we've had his coworkers test positive. And so trying to figure out how we're going to balance that, whether we see family, whether we isolate, all those things coming, and how long we do that for, when he gets a test. There's a stigma in admitting need, especially for us who are the ones that are helping others. Often we're less likely to ask for help because we see that as weakness when we're the ones taking care of others. And the next line, you're used to prioritizing the needs of others above yourself. And in the midst of all of that, many of us are suffering from grief and loss and not able to grieve in the ways that we would have prior to COVID. So our healthcare workers are facing a lot, whether it's medical or behavioral health. So here is just a long list of all kinds of warning signs, whatever label you want to put on it. When I showed that list of different terms, a decreased ability to concentrate, to be creative, to listen, minimizing your own issues, some of those PTSD symptoms that I talked about, living with guilt and fear beyond what you should, chronic exhaustion or getting sick, feeling helpless and hopeless, feeling that need to step in and rescue everyone all the time, addictions, losing your ability to empathize, blaming people around you, justifying. You're seeing a lot of anger, cynicism, people complaining, those kinds of things. Those are all warning signs that some really negative things could be going on. This is a list of risk factors. So many people can be hesitant to set boundaries. I know, again, taking out of my own personal life, within my own family, there have been discussions too when family members have been exposed, and some are fine with still meeting and others are not, and there's been tensions there over that, and I've had many friends relay that too. So in that need to set a boundary at different points, some people don't want to because they fear a loss of love from someone. They don't want to feel abandoned if they do that. At work, if they try to say no to something, they don't want to lose employment, don't want to be viewed as mean, don't want to feel someone's anger, or they might just not be sure what boundaries they should be setting when it comes to COVID. So there's all those stressors taking place. And in the midst of all of that, if someone's not taking time for self-care, they're at increased risk for all the things we've talked about. And when I talk about self-care, a lot of people, even at the word self, that kind of triggers something where you think that's selfish to do self-care. But it really is a way that you can get yourself into a place where you can provide for others in a very healthy way. But if you have minimal self-care, if you're not taking time for yourself, not eating healthy, not socializing to the best of your ability under our circumstances, engaging too much in numbing activities or isolating, or on the other hand, lacking the boundaries that should be there, can be putting yourself at risk. So this is just a big, long list of more things at work. If you're working too long without checking in with colleagues, or too long without taking plenty of breaks, if you're feeling like you're not doing enough and blaming yourself, if you're eating unhealthy, sugaring up, caffeining up at work, talking to yourself, if you catch yourself. We all have, I still use the word tape recorder, even though I know we're way beyond that technologically, but we all have a tape recorder in our head. And we talk to ourselves all the time without realizing it. So if it is a thing of, it would be selfish for me to rest right now, or everybody else needs me, only I can do this, those kinds of things are not healthy self-talk. And so we want to be aware of what we are saying to ourselves and what we're really training ourselves to believe about our environment and our place in it. So moving on to some tips for self-care. We all need someone to talk to. We're just built that way as human beings. We do need someone to talk to. So finding that person or those people is really important during this time. Understanding that if you are feeling pain, if you are feeling sadness, that that's normal, but also at the same time noting that you have felt sad, you have felt isolated, you have felt probably most of the things you're feeling in the past, and you've been resilient and moved on from it. And just taking a moment to stop and note that most of us in very difficult times, for the most part, we may feel sad or low, but for the most part, most human beings become more resilient because of it. We don't reach the full-on devastated, burnt out, needing professional help place. If we do, then we absolutely should be reaching out for it. But most people become more resilient. And for various reasons at different points, certain instances or certain traumas can impact us in a way where we can't quite move on from that, and we do need to get help. But most people become more resilient. So that is a positive in the midst of everything. We need to be engaging with our culture, with our community. So as Native people, if those are, if you have pieces of your culture that are important to you, now is a great time to engage even more than you were in the past, to engage in your community, to learn to say no, or to talk to supervision when you are overwhelmed so that you can have a life-work balance, and determining what that really looks like for you, to practice self-compassion. So when I use the term self-compassion, I don't think that's a term, at least for me, that I hear a whole lot, but it was something that I came across and I really liked. And so I wanted to read to you guys just a little bit about that. There's some growing research on it, but it's really about extending kindness to yourself, and not not in a selfish way, but kindness to yourself rather than the judgment, the self-talk I was talking about before that can be really damaging and just take us to a really low place. It's extending kindness to yourself in the same way that you would to your neighbor. And it's learning to see what you're feeling and what you're going through as a larger part of a human experience. So in some ways, it's practicing mindfulness. And when I hear the term mindfulness and I listen to people talk about it and I read about it, there's a whole lot of different ideas about what mindfulness is. So I'll just tell you, when I'm talking about mindfulness, what I'm referring to is just really being aware of the present moment and your thoughts and not judging them, but just knowing, oh, okay, I'm having an anxious moment. I recognize it. I'm not beating myself up about it. I'm not praising myself for it. I'm just recognizing that's what's happening, and maybe I've got to move through this right now, but I know what's going on with me and I know it's going to end too. It's just being aware of the moment. And there's more you can do in mindfulness, and we can talk about that at some other time if you would like to, but I just kind of wanted to touch on it. But really, practicing self-compassion allows you to then be compassionate with other people, because it gives you room and it gives you space to not be stuck in some emotion, but to just be aware of it. Feeding your spirit. So whether you go to church or whether you practice spiritual activities individually, however you do that, feeding your spirit is very important. As Indian Health Service, we talk about raising people to the highest level possible, physically, emotionally, and spiritually. So we don't want to leave that piece out. That's a part of who we are, and it's very important. Engaging in activities that increase your joy is important, and doing it intentionally. Otherwise, those things can slip to the side. So right now, lots of people are talking about self-care plans, and it may sound cheesy to some people, but it's a really good thing, because if we don't have plans, if we're not intentional, things don't tend to shift or change. So it is more likely that you will actually engage in exercise, nutrition, sleep, creativity, spiritual activities, all those things, a work to home transition plan that is healthy for you. It's more likely that you will actually do those things if you create a plan for yourself. when we are intentional about things, we are more likely to hold ourselves accountable for those things. On one of my last notes, though, on tips for taking care of yourself, if you stay in a negative place for longer than several weeks, if it begins to interfere with your functioning during that time, then it is time to reach out for some professional help. May just be that you just need to talk to someone for a while, but that's a point where it's dragging on to that point and you're not coming out of it, and it's interfering with your ability to function in life. That's time to reach out and get some professional help. So for organizations, there's a lot of things that organizations can do to show employees that they're supported, and to, it works well on both sides. Organizations are benefiting from benefiting from that support. But the promotion of self-care plans is a good idea. That means you're talking about it. Maybe you're sharing them with staff, offering trainings on things like this, on fatigue and burnout. Again, lets employees know that you care and gives them practical tools for moving forward. COVID-19 preparedness training and planning. So what I mean by that is what everybody probably already is doing, but staff feeling like they know what to do in all the situations that arise around COVID-19, the training they need, and even the planning exercises they need to address the different situations that are coming up. Monitoring and assessing well-being, so that's supervisors looking out for their employees. There are actual assessments that exist for wellness in organizations. I'm not promoting any of them necessarily. I'm just letting you know that they do exist if they were things you wanted to look at, like actual surveys that employees can take that help you understand better where your employees are sitting with their well-being. But within our own culture, there's also room for very simple things like socially distanced talking circles that give people opportunity to talk about well-being, those kind of things. And then creating a culture of wellness, which is something that I'm very interested in personally. Different companies are doing this, and some are doing it really well. They can tie employee wellness to a supervisor's employment review, so that it becomes a core of what that system is doing. With what every supervisor is doing, it becomes part of their job. You can tie it to employee incentive programs. I've seen tiered programs where if you're just working out on a regular basis, you get this reward at work. And it doesn't necessarily, some of them are giving financial rewards or time off. Some of them are doing other creative things because they don't have that option. But at every level that they have defined in these 3-tiered programs, as employees move up, they get more and more benefits for it. That is a way to really engage your whole system in wellness. For your leadership to not only be discussing wellness, but to be sharing examples and leading by example is great if you want to see changes in your employees and have them actually feel comfortable in engaging in wellness activities. And then to also think about supporting the family members of providers and reaching out beyond that, especially in healthcare, knowing the stress that is on a family. And like I said, in my own family, my husband is not in healthcare, but he is in the community all the time serving. And so he is constantly exposed and to some of the stress that has put on our family, to know that, and that we are taken care of in those situations is a great support for us. Lastly, I was going to show you, I have, like I said, I'm just reaching out and starting to meet people, but I've been asking when I meet with people what they are doing to address stress for their healthcare employees. And so I was just going to share with you some of the things that I have heard from tribes and tribal organizations. So Mississippi Band of Choctaw Indians, this is a picture that you can see on this slide, and they are creating de-stress zones within their hospital, and I think probably within their outlying clinics. But so you'll see there's actual massage chairs there. I have not heard the term plant therapy, but they talked a lot about plant therapy, and I looked at different pictures, and they have lots of green plants everywhere in their de-stress zones. And they have essential oils. They have the opportunity to color while they're in there. They have soothing music if they want it. They have a lot of options, but just a place to come. And then they've printed up things, suggestions for people on the doorway there as they come in to help them to have a place to come in and just be calm for a while. They've also developed a podcast, and initially it was to cover grief. So there's a 4-piece grief podcast, which they're planning to use to move into grief groups because they've been hit so significantly by COVID in their community. So they're trying to find ways to start those conversations. But they're thinking they're just going to keep going with the podcast, and they've got some about stress and some about other mental health topics. Other organizations talked about that they are having monthly craft activities for their employees, and the first one was painting. Another one was creating wellness baskets for their staff. So those have everything from essential oils and massage devices to sleep masks and pedicure at home kits, weighted blankets, and those kind of things. So those were just some of the really cool things that I saw, that I heard were being used right now. And I wanted to kind of close out just with this last piece that says clinician wellness serves as a protective factor against vicarious trauma for clinicians working with traumatized clients. So really the greatest thing, we want to help people when we see they're in trouble, and that's why I had warning signs and some of those things that you can see, and maybe reach out to someone if you see that they're struggling. But the greatest protective factor is their overall wellness. So creating those cultures of wellness is one of the best things that we can do for our employees. There's resources on the last slide. And then a lot of what I pulled, SAMHSA has just so much, but I left them at the end, even though they're cited on the slides, if you wanted to go back and look at any of these topics in more detail. And that is it for me. So I will open it up for questions or discussions. And definitely, if anybody's heard of any creative ideas that people are engaging in for wellness, I'd love to hear about that. Thank you.
Great. Thank you for a great presentation, Jennifer. Do we have any questions?
I have a question, and a wonderful presentation, by the way. Do you have data on the frequency of burnout in our health providers?
I don't have any data, not in ours, and definitely within the Indian health system. I don't think that we're gathering anything on that. I've asked questions along those lines, and I think the most that, at least across what we're hearing within incident command structure, which is where we're meeting to talk about COVID, is really just area directors coming in saying, we're concerned, this is what we're seeing, this is what's being reported, but actual data being gathered, I'm not aware of anything.
Thank you.
Anything else before we move on?
I love everything you shared. I'm very excited about all these ideas. I think a subset of us is organizing, I think they're back to school wellness kits that they have like aromatic putty, like play putty and stuff in it. And
Okay.
I don't know very much about it.
That's really cool. I was going to say too, I didn't really go into detail, and you guys are probably aware of it, but on the resources slide, there are lines that have been created just for providers that are 24 hours, or text lines and phone lines for people who are experiencing stress, to have someone to call in a moment of crisis. And I didn't point that out, so I just wanted to go back to that.
Okay, we can move on to Dr. Mera with his COVID-19 updates.
Okay. So I'm going to talk about two topics today. One is the use of steroids in patients with COVID-19. There's been some new data that came out last week. And the second one is reinfection with COVID. That's something that's asked a lot, and we also have some new information on that. So the first thing is, I'm just showing here, I'm not going to go over each one, 3 trials that were published last week in JAMA, and they each one is the evaluation of steroids. In some it's dexamethasone, in others is hydrocortisone, and one that I don't have here was methylprednisolone that just got published in New England, I think 2 days ago. So these are very good studies. The problem is that many of these studies had to be stopped before their recruitment goal, because on June 9th, the recoveries trial from the UK came out saying that dexamethasone decreased mortality. So it was unethical to continue enrolling patients on steroid trials for this specific, very sick population. And so if you go through these trials, you will find some things that may be significant or not, but at the end of the day, it's difficult to capture if steroids work or not because of the smaller population that was studied in each trial. But the good news is that the WHO predicted that this was going to happen, and a group of researchers started a project which basically consisted of identifying all the trials that were using steroids in patients with COVID-19 and had a progression of disease. They identified 16 trials, and then they screened all these trials to make sure they met the inclusion criteria that these researchers were looking for. And of those 16, 7 trials were excluded because of either the intervention was not the one they were looking at, or the study did not recruit any patients, etc. And so they ended up with 9 trials. So they proceeded to contact those investigators and ask them, would you share your data with us so we can start pooling the data and see if we can come up with an answer to the question a little bit faster than each one individually. And 7 of those 9 investigators responded positively, which is, you have to really appreciate that, because it's very rare that an investigator is going to release the data they're collecting before their trial is ended. But, understanding, and to give credit to the previous speaker, being compassionate about the situation, they did share their data. So this WHO group did a prospective meta-analysis. And it's not very common to see prospective meta-analysis. Most of the ones that we read about are retrospective. So this prospective meta-analysis included 7 multinational randomized clinical trials that were evaluating the efficacy of corticosteroids in critically ill patients with COVID-19 from February 26 to June 9th of 2020. And they were able to collect data on 1,700 patients. The exposure was the steroids, and the outcomes was mortality at day 28. That was the main outcome that they looked at. Second one was adverse events. So what did they find? Out of those 1,700 patients, the median age was 60 years old. 29% were women. Most of these patients, but not all, were on mechanical ventilation. And this is important to understand because although we will have some conclusions of this study, we don't have all the questions answered about when steroids should be used in all the patients. So when they looked at mortality at 28 days, which was their primary objective, they found that 32.7% of the individuals who were randomized to steroids died, compared to 41.4% of those who did not receive a steroid. In summary, the odds ratio of death was lower if you were on steroids, and the confidence intervals were below 1, so that made a strong statistical significance of their findings. When they tried to tease out between the different steroids that were used in the trials, the only one that had a consistent and strong statistical significance was dexamethasone. Hydrocortisone was the second one. And then last but not least, methylprednisolone was the one with the weakest association to decreased mortality. Although when you look at the odds ratio, all of them decrease mortality. They're all below 1. But when you look at the confidence intervals, for dexamethasone is the only one that the confidence intervals are still below 1, the minimum and the maximum. Here you see an overlap. And basically this is, I mean, one reason is the number of patients that were in these trials. They were able to analyze over 1,200 for dexamethasone, but less than 400 for hydrocortisone and less than 100 for methylprednisolone. So maybe this not so strong effect for these other two steroids were because of the volume of the patients enrolled. The other reason is that they may not work as well. But it is thought that this is a class effect and not an individual steroid effect. When they looked at adverse events, they found actually that only 18% of patients on steroids had adverse events, serious adverse events, and 23% had serious adverse events when they were on placebo or standard of care. Now, as a reminder, serious adverse events are defined as death, the need for hospitalization, which doesn't apply here because everybody was hospitalized, but prolonging the hospitalization, or causing discapacity are the main. There's other classifications, but that's the main one. So the conclusion was that administering corticosteroid was associated with decreased mortality. There was no suggestion that it increased the serious adverse events. The odds ratios were similar for dexamethasone and hydrocortisone, but it was only statistically significant for dexamethasone. Lower mortality happened in both groups, the patients that were on mechanical ventilation and those that were not. But when you actually analyze these two groups separately, it seemed to have a higher impact and decrease in mortality when you were not on mechanical ventilation. Patients who were in shock did not have a beneficial effect of steroids. There could be a bias in this group because most patients who are in shock get steroids. So you were not allowed to participate in the study if you were already on steroids. So they actually analyzed that interesting subgroup that for whatever reason were not receiving steroids despite the fact that they were in shock. When they looked at other variables like age, gender, and duration of symptoms, they could not find any association between those variables and decreased mortality when using or not using steroids. So what does this mean in simple terms? That if you treat 100 patients that are critically ill with COVID-19, 68 will survive if you use steroids, and only 60 will survive if you don't use steroids. So you're giving the opportunity of survival, at least at day 28, to 8 more patients out of 100 when you use the corticosteroids. The number of patients you need to treat to benefit one is 12. Unfortunately, we don't know which one it is, so we have to treat all of them to obtain that benefit. So this meta-analysis was editorialized, and the person who wrote the editorial made 2 major comments. The first one is that now we have consistent evidence that steroids benefit patients who are critically ill with COVID-19, and they decrease mortality. And also that we have identified an effective, inexpensive, and relatively safe treatment for COVID, for people with critical illness and COVID-19, and that gives us some more hope. The other thing that this person mentioned was that we have to really praise those researchers who were generous enough to share all their data before their trial ended for the common good. And we still have a lot of questions about steroids. Could different doses be useful beyond the ones that were used in those trials? Could we taper the dose of steroids based on biomarkers? most of those trials use fixed amount of days, either 5 days or 10 days. But could we use a more specific tool to gauge the amount of days the patient should be on steroids? We know that some patients, when you take them off steroids, they rebound. So should we taper those patients? We don't know that. The adverse events in these trials was not as strict, the reporting, as it in other types of trials, due to the need to do these trials really fast under this pandemic. So maybe we need more information on side effects. Should less severe or patients that are not hospitalized, or that are hospitalized but they're not critically ill, should we be using on steroids on them? So by the recovery trial, the one done in England, said no, because actually there seemed to be a more deleterious effect on those patients. But I think we need more data to clarify that. And do steroids have anything to do with viral clearance of COVID-19, especially in patients who are not that ill yet? And finally, we use, at least in Cherokee Nation, everybody who is critically ill, we offered them remdesivir, plasma, and steroids. And but we don't really have any data on the combination of these treatments, if they are better, the same, or antagonistic for that matter. And we need more data on that too. Okay, so switching gears, let's talk a little bit about reinfection from COVID-19. So this is a very interesting article published by Paul Sachs in ID and HIV Observations in Journal Watch. And so before he starts answering the question of, is reinfection possible and what are the implications, he kind of shows us that there's many things we don't know, and many other infectious diseases that we've had for years, or for centuries, more than years. Some examples are, why does one parent never get sick when their kids start coughing and sneezing and dripping with colds, while the other parent gets a cold every single time? And why do you go to dine in a restaurant in Mexico, or it could be anywhere for that matter, and someone gets severe diarrhea, or a group of people do, and the rest don't suffer at all? We all get infected with Epstein-Barr virus, but the majority of us don't experience any symptoms. And some people do, and some people get really sick and have poor outcomes. And why is that different from one individual to the other? And again, with influenza, some individuals get 2 flu infections in one season, and then you all heard about people saying, I don't take the shot because I never get the flu. So there's a lot of things that we don't know. So we shouldn't be surprised that we don't know so many things about COVID, especially since COVID has been around us for only 6 months now, or 8 months. So for those of you who are very worried about reinfection, there's a COVID-19 Reinfection Tracker. I think that's going to get you more psychotic than give you peace of mind. But if you are interested, you can click on this link I put on the bottom of the chart. So far there's been 8 cases reported of reinfection with fairly good data that it could be possible. If you want the details of each study, you click on details and it'll pull up the paper or the preprint or the Facebook news about it, because some of them are still not in scientific journals. I'll discuss 2 of those cases. One is the first one, the Hong Kong case. So this is very interesting because this patient had COVID, symptomatic COVID, not the severe. He got over it, and 142 days later, he landed in Hong Kong airport, and they have a policy of screening, I don't know if everybody, but a certain amount of the passengers, and he got screened and he was COVID positive. Now the second time he was completely asymptomatic, and he did have an antibody response to that infection. And he did well. I mean, he never got sick, but these researchers were able to sequence both viruses. They had both viruses, the one of the first episode and the one of the second episode, and the virus was different. And they say that that was an infection due to a different COVID, SARS-CoV-2 virus. So this is probably the first confirmed reinfection. The second one that happened in the US, in Nevada, still has not been published and peer-reviewed. But the bottom line is that a patient got COVID, he was symptomatic, but he got over it. And then 2 months later, he gets really sick again and then ends up in the ICU, and he has another COVID virus. And apparently, I mean, we need to wait for the publication, but apparently this virus was sequenced, and it was also a different COVID virus. In this case, it's a little more scary because the first patient, the Hong Kong patient, probably he just had a first infection, a good immune response, and when he got exposed to the virus the second time, he dealt with it well, and that was just diagnosed because he happened to be tested. This case had an infection and then had a really, really bad infection. And this reminds me of dengue. Dengue, when you get the first infection, you do fine or you're asymptomatic. It's when you get the second one that your immune response causes hemorrhagic fever or hemorrhagic dengue. So maybe this happens in a subset of patients. But the good news, I think, is there's been 8 reports in millions of cases that we've had. And of course, many probably have not been detected or reported, but even so, if reinfection occurs, it's probably not very frequent, at least symptomatic one. So Dr. Sachs goes and, he poses a lot of questions and gives some answers. How often does reinfection happen and why? So it doesn't appear to be common, but it does occur. So we have pretty good evidence that it can occur, like it does with other coronaviruses. Will cases be as severe as the first infection? Well, you had presented 2 cases, and one of them, the answer was no, and the other one, it was worse. So maybe it has to do with the inoculum. I think an important message that comes out of all these public reports is that people should not think because they got an infection, they're immune, and they should still protect themselves from future exposures. And then how does this affect our policies? Because right now, if anybody's COVID positive, we tell them for the next 90 days, you don't need to be retested unless you're symptomatic and you can't, and you don't have a good reason for those symptoms. But now with reinfection being possible, this may change our policies. Right now, it hasn't, but we just have to be, watchful for that. And the fact that there's reinfection, does this preclude a vaccine? Not really, because we have other infections like HPV, in which actually the vaccine gives you a lot better immunity than the natural disease itself. So this should not be a major barrier. And that's all I have for you today.
Great, thank you. Do we have any questions for Dr. Merritt? Just a reminder to sign in to the link in the chat. And do we have any questions for Dr. Merritt?
Hi, it's Dr. Johnson. Can you hear me?
Yes.
Okay, great. Hi. I want to be, for everyone that's on the call, on pulmonary critical care. So I wanted to make sure that we address or ask some questions related to the steroids. Just because I've seen several protocols now where people are starting to use steroids as basic treatment for COVID-19 patients, and they're sending them home outpatient even with steroids. And I wanted to start off by saying that that is not currently the recommendation, that we needed to be clear that it is critically ill patients. And the thought behind that from the critical care perspective is there is a cytokine storm that occurs, or severe inflammation, that the steroids have shown to actually improve. Society of Critical Care has been plus or minus and said it's really weak evidence related to steroid use in ARDS. So it's really, really still controversial. There's a lot of information that's out there, but I know that there is that Brigham and Women's COVID-19 protocols that people refer to, and what their protocol is use of steroids in critically ill or patients requiring supplemental oxygen. And it's really weak evidence based on a article or research that hasn't been published yet. So I wanted to get your thoughts on that new practice. Are you recommending that we now continue that protocol of just treating critically ill patients? Are you recommending any hospitalized patients? Where in general are we looking at with steroids?
Oh, thank you, Dr. Johnson. That's a great question. So yes, the answer is the patients that need to be hypoxic. So when you look at the recoveries trial, the first one that was published, and I think in June, they showed a benefit in patients who were on ventilators and patients who were not on vents, but had the definition on their trial was required oxygen. that were on oxygen. And that's one thing that has a little bit iffy because not everybody gives oxygen with the same parameters. But having said that, you need to be requiring oxygen. I am assuming you're hypoxic or have less than 94% of saturation, or be critically ill in a ventilator or receiving non-invasive ventilation or whatever. So it seems that in that group of patients, it does help. And you will see that, like the methylprednisolone trial was published in New England recently, and they did not show a benefit. But it could be the volume of patients. It could be the number of patients is not enough to, show the evidence. When this group from a WHO pulled all the data and did a very strict meta-analysis because they were in communications with all the authors of the other trials, and they were getting all that data and detail from them, they found that there is a benefit in critically ill patients that are mainly on vents and also hypoxemic and require recurring high flow oxygen, or at least more than 6 liters of oxygen therapy. And those, we know that there is a benefit. Now, we don't know in patients who are without oxygen. Actually, on the recovery trial, patients without oxygen, as steroids seem to be a little bit deleterious. It was a little signal there without statistical significance. So there is concern of using it in patients who are not hypoxic because it may not help, and it may actually decrease viral clearance for all we know. So we are in Cherokee Nation, we're following the guidelines, and we use it only in patients who have hypoxemia, defined as less than 94% oxygen saturation on room air. And I think there need to be more studies on that other subgroup to see if there's any benefit, because it's a very fine line between being hypoxemic or not and getting to that point, because as you all know, a patient will start going south, but it'll take hours or maybe a day or two until they become hypoxemic, and maybe that's when you have to start the steroids, but we don't have that guidance yet.
Thank you for that question, Dr. Johnson. Do we have any other questions for Dr. Mera or Jennifer Downs? Hearing none, we can go ahead and conclude today's call. Don't forget to fill out the evaluation in the chat. It helps us with future clinics. So anyway, have a great weekend and be safe.